So we shall now go on to our next speaker, Dr. AKSHAY Nair, a very dynamic, prolific oculoplasty surgeon who's specialized in cosmetic oculoplasty, ocular oncology, facial aesthetic, and ophthalmic plastic surgery. And he is presently practicing at Advanced Eye Hospital Institute, which is part of Agarwal Group, collaborated with the Agarwal Group of Hospitals. Am I right, Dr. AKSHAY?
Yes, ma'am. We are all yeah. Fortunately, unfortunately, all the three hospitals that I work at are now all a part of the Agarwal's group of hospitals.
Okay, very nice. And I have heard him talk in earlier ARC webinars, and I really look forward to a lot of learning which will come through. On to you.
Thank you so much. And I think I'm honored and privileged to be speaking on the same platform as my mentor, the teacher who taught me every lacrimal surgery I know, Dr. Javed Ali. So the aim of this talk and the target that it is, the target audience is practicing oculoplastic surgeons or even fellows and residents. External DCR is taught and practiced in day-to-day oculoplastic practice. So I hope that by listening to this talk, we can ask ourselves, those who are not yet doing endoscopic DCRs, is should I start doing endoscopic DCRs? Possibly, can I start doing endoscopic DCRs? And hopefully, by the end of this talk, you can ask yourself, how do I start actually doing it? Because that is what I'll be trying to explain. So in a way, this is a blueprint for how to take the leap from endoscopic to external to endoscopic DCR. So before you decide, there are multiple things that you need to have within your reach available to you, and also a few things that you need to take into consideration before planning to actually offer this surgery to your patients. The hardware, the instruments, the economics, and how to maximize outcomes in this surgery. So before even ending up to buying an endoscopic DCR equipment, you need the skill set to start doing endoscopic DCRs. So there are two ways you can do this. Either you get the endoscopic DCR and start doing it or learning it and practicing endoscopy before you actually end up doing endoscopic surgeries, or you try to get the skills, everything except actually doing the surgery before you start doing it. In the sense, you undergo an observership, go see other surgeons doing it, possibly attend cadaveric workshops, and then come back and start buying it, then get your endoscopic equipment and do it. So one way of doing it, or at least the way that I build upon my endoscopic skills, was getting the endoscope and start doing endoscopy in the OPD, in the OR for probing cases, for simple NLD probings. Or once you made the ostium in an external DCR, remove the pack, put in an endoscope, have a look at what the anatomy is, have a look at where the ostium should be. Or in your tube removals in the OPD, you can just visualize where the tube is or where your stent is. Or like was mentioned by the previous speaker, stent prolapse. The best way to manage a stent prolapse, put in an endoscope with a long forceps, just gently prolapse the tail of the stent back into the nasal cavity. So pre-op endoscopic evaluations, post-op endoscopic evaluation. Remember, the most important thing about an endoscopic DCR is not actually the DCR, it's the hand-eye coordination and the ergonomics of being able to look up at the screen and operate with both eyes, both hands, holding two different instruments at different points. There are multiple cadaveric courses that offer you real cadaveric experience on endoscopic surgeries, on external DCRs, on every procedure. You can look them up online. You can find good courses in India and abroad where you can master these, the skills required. And this is only not just from the ophthalmic domain, even the ENT domain. So before you jump, you need to maximize what you have in your OR. Like Deepthi mentioned, a lot of factors that will not usually be discussed, such as the space or the area that you have. Most oculoplastic surgeons may also be doing cataract and refractive surgery, or they may have small ORs which may not allow them to put in a lot of instruments. So you need to be able to maximize or optimize whether you will be able to get in your endoscopic equipment in the OT as well. Small things like whether you have plug points or UPS that can support the electricity load of an endoscopic equipment. For a beginner, always prefer GA for endoscopic surgeries before starting to do them on LA. Remember, the surgeon comfort in the ergonomics, the equipment, the instrument, the anesthetist is as important as patient comfort as a beginner. For a beginner, you need to be comfortable completely. Only then will you be able to give the optimal outcome to your patients. Then have a look at the outcomes. So when we talk about an endoscope, this is the endoscope that we use. There are three parts. There's the camera head, which you can see. There's the fiber optic cable, which is attached to a light source that brings the light at the end of the endoscope. So each of these equipment, these three components of your endoscopic and your endoscope are separately bought. This is a camera head, which is the attachment for all endoscopes. It's a soakable camera head. It can either, the high-end ones have high-def CCD chips with multiple buttons that allow you to start recording for image adjustment, for window adjustment. They can even have digital zoom. What you need to see is the compatibility with endoscopes. Just like if you're going to buy a phaco handpiece, you want to make sure that your phaco tip is compatible with the machine that you're buying, because one, you can't buy, say, of one company and you expect it to work on the other. You need to make sure they're compatible with all endoscopes. The next thing, which is the most crucial part, is your fiber optic cable. Prefer a standard company. They are expensive, but they are worth it. These are autoclavable. And like I said, you need to see whether they are compatible. Typically, fiber optic cables have a standard male-female outlet, which means they are compatible with all companies. And finally, the endoscopes. We prefer to use rigid endoscopes that have a scratch-free sapphire lens objective at the end. They are available in different sizes, either 2.4 mm, 2.7 mm, 4 mm, multiple sizes based on the diameter that you need to use. In pediatric, these endoscopic equipment, you might want to use small diameters. In adult, you can use a 4 mm diameter or larger ones. The angulation, as you can see from the side, it can either be an end on flat 0 or even a 30-degree angulation. These are also autoclavable. And as is for most ophthalmic or any surgical equipment, you may also have third-party vendors which are compatible with a standard company. So, and they of course offer the equipment for a cheaper cost. So you should always check, especially if you're buying from a third-party vendor, whether it is compatible with your endoscopic handpiece, with your camera head or not. And finally, your light source. So when you talk about light source, there are two types. There is a halogen light source or the LED light source. Now, the halogen light source is cheaper. The life cycle, however, is much shorter. And you can see in this graph, the operating life for each lamp is about 300 hours. But whereas that for an LED is much more. So while your recurring costs for the halogen may be higher, your initial cost for the halogen may be lower, your recurring costs are much higher. So based on your usage or your expected usage in the future, make a choice on what you want to buy. Now you've got the endoscope with your camera head with the endoscope, your fiber optic cable with a light source. All of this, especially your camera head wire, goes into the camera system, which is basically the image processing units, which connects and shows up what you see on the endoscope on the large screen. It can either be an HD or a standard processing unit. Some of them allow you to only record still images. Some of them allow you to record movies. Sometimes you can get a combined, the standard companies allow both a camera unit as well as a light source combined into one. Some of them offer you separate, so you are able to customize them. Now, this is what a standard endoscopic suite from Karl Storz, which is probably the endoscope, the industry leader in endoscopic equipment, along with Olympus. So you can either go for a HD equipment or standard. Based on the size of your OR, your screen, you can decide what you want. Portability is another issue. Now, that tiny little thing that you see on the right side, that image, is basically what is called Storz Telepack X. It's an expensive bit of equipment, but it's portable. That has everything. That has the screen, the camera image processing unit, as well as the light source, all built into one, and it fits in a briefcase that you can carry around. The latest model of Telepac, which is what the model is, has an HD screen. And not many people know, but close to the first 100 DCRs, endoscopic DCRs that Dr. Javed did was on a similar Telepac X that he got at LVPI. And we used to shuttle that as fellows from the OP to the OR. And even my first endoscopic DCR was done on that. So, if cost is an issue and you also want portability to fit into the role of a freelancer that Dr. Deepti mentioned, maybe this is what you need to think of getting.
1 minute.
And then you have the separate set of instruments. Now, endoscopic instruments obviously are different. You need your long forceps, which are usually the Blakesley forceps. You've got different serrated ones. You've got flat-tipped ones. Your forward biting punch, your backward biting punch. Suction elevator is actually an instrument that I even end up using sometimes in an external DCR, which basically has a suction tip, but has an opening at the tip of it. And it is hollow inside and can be attached to a suction cannula, which basically allows you to elevate the periosteum or elevate or retract soft tissue while constantly doing suctioning. So it clears your field as you go ahead and do it. A ballpoint probe and a sickle knife are very, very useful instruments, as are some instruments that you can borrow from your neighboring cataract surgeon, which is viscoelastics, and a crescent knife, which I use to open up the lacrimal sac. Fill up the lacrimal sac with viscoelastic and then open it up. So once you've got the hardware and the skills, then you have to look at the economics of how much does getting all this hardware really cost. Top of the line is Stryker and Karl Storz, which can go up to 25 lakh rupees. But if you need to go for basic starting equipment, you can get a basic screen with a camera and an illumination system, a rigid endoscope, for close to 1.5 lakh. Indian equipment can be mix and match up to 4.5, 5 lakhs. Your additional surgical instruments can be up to 1 lakh. So in general, to get going and hit the road running, for value for money, endoscopic equipment and instruments which are of decent quality, Indian made, will push you back by about 5 lakh rupees. Additionally, you may want to get drills. Drills can be of good quality because remember, as oculoplastic surgeons, most of us already have drills that we use for our decompressions and orbitotomies. So at the end of it, like I said, you need to optimize. You can use the same endoscope for probings, for OPD procedures. In the beginning, you may want to have an ENT surgeon whom you can visit and watch some cases. And you should always maintain a good friendship with an adrenaline-friendly anesthetic who doesn't mind you, going a little overboard with anesthesia, because the biggest concern that a beginner endoscopic surgeon can happen is the moment there is a little bit of bleeding or you touch a mucosal surface at the wrong angle, your view gets obscured. So you need to come back again, dip it in Savlon, clear the screen, check your white balance, and go back in. You end up doing this about 30, 40 times in a surgery. It can get on your nerves. So if you've got a really good avascular field, it is very, very useful in reducing the surgical time as well. You already have wireless Bluetooth-enabled endoscopes. You already have endoscopes that can be attached to a mobile phone and allow you to do this in your OPD and record the images on your phone. So learning the on-the-job is not new in ophthalmology. You think of the Doyens in retina surgery, in cornea surgery, the Natarajans, the Samar Basaks. They didn't have vitrectomy and lamellar DSECs and DMECs when they did their training and came into practice. They learned all of this on the job. OCTs in regular ophthalmology is a phenomenon that we saw only in the early 2000s. Before 2000, there was no OCT machines. And yet, bulk of the retinal practice nowadays is intra-VEGFs based on OCT and OCT angio. How do retinal surgeons who've learned more than 20 years ago adapt, transform their surgical skills, and now make it the mainstream on which their livelihood is based on? They learned on the job. So don't be afraid. Remember, endoscopic route is the future, because as patients get more savvy, more tech savvy, they read more about surgeries, they choose their doctors accordingly, and literature is now going to show you that endoscopic has equal, if not better, results than routine DCR. They're going to choose a surgeon who's more adept at endoscopic DCR, which is why it's better now than later. And I may have discussed the economics of how you can start with the basic equipment. Eventually, you need to upgrade yourself for the best. because as you do more, your skill will polish itself and it will pay for itself. Do it now to get the earlier bird advantage later on. So no longer do you have to tell a patient, I can't do it, and you need to go and do the endoscopic DCR from an ENT surgeon. With that, I'll wrap up, but not without taking your time to invite all of you all for the annual conference of the Oculoplastics Association of India. I'm privileged to be one of the organizing secretaries in Mumbai. It's 11th to 13th November. The early bird registration and abstract submission ends on September 15th. This is our first in-person meeting in 4 years. So please make it a point to travel to Bombay and be there. We'll be happy to host you and make it a great meeting. Thank you so much.
That was a wonderful talk. Actually, it should have been a debating talk, but I think why we did not make it a debate was people would have lost badly to you. That was so convincing a talk of yours. So we shall, thank you. Shall we go on to our next speaker?
Yes, madam. I don't think Akshay has left any room for any.